Hi everyone, this is Nicole Struthers. I'm going to go over your thymectomy prosection today. So there's a couple reasons why you would receive a thymectomy in the gross room, right? We know our main reason why we're going to receive a thymectomy is that it's an incidental situation. A patient goes in for open heart surgery and it's kind of in the way, or we get into our pathologic reasons why we might have a thymectomy. Those would be our thymomas or our thymic carcinomas, or treatment purposes for other disease processes like myasthenia gravis. So orientation wise, there's not a ton of orientation for thymectomies or thymi in general. If your surgeon provides you orientation, that is super helpful, or if you have some adherent structures, that might help you determine orientation. In this instance, we received our thymectomy fixed and it doesn't have any orientation. So we're going to proceed as an unoriented thymectomy specimen. So first thing we'll do is we'll weigh the specimen. It's 42 grams. Then we will measure our specimen in 3D. So it's 9.4 by 5.4 by 1.7 centimeters, and that's our specimen overall. Usually there's going to be a lot more adherent soft tissue and adipose tissue to the outside of the thymus. In this instance, we have a little bit, but not a ton. So after we've taken our weight and 3D measurement, we can describe our outer surface. We're always going to work from outside to inside. And in this instance, we have a really nice tan pink, smooth and glistening outer surface. It's not disrupted. We have this little area that's kind of roughened. So I would say I have a 4.7 by 2.0 centimeter roughened possible area of disruption on the capsular surface. Otherwise, it's really nice and smooth and glistening. Some things that could be adherent. So we know that our thymus lives in our anterior superior mediastinum, right? So the only thing that's anterior to the thymus is going to be our ribs and our sternum. So there's not really going to be any organs that could be attached anteriorly, but on the posterior side, we have lots of structures that could be stuck to our thymus. We have our heart that's directly behind there, so our pericardium could be attached, the pleura, or even the lung. So we want to document and describe anything that's adherent to the outer surface. At this point, we've given all of our descriptions of our outer surface. We can go on to inking. So since this is an unoriented thymectomy, we can ink it one color. If we received any orientation, we would be able to differentiate between anterior and posterior. Those are going to be our big directional orienting features that we would want to document, because we know anteriorly we have not really anything, but posteriorly we have our pericardium and possibly our lungs. So if we could orient it, or we had orientation by the surgeon, provided by the surgeon, we could ink two colors and you would differentiate anterior versus posterior. All right, so we're entirely inked here. After we ink, we can use our mordant. All right, so now we can serially section our specimen perpendicular to our long axis. So the things that we're looking for on our cut surface, depending on what we receive this specimen for, if we're thinking of a thymoma, we're going to be looking for those thick fibrous bands running through our cut surface of our lesion, versus if we have a thymic carcinoma, then we're not going to be concerned about the fibrous bands. Those don't exist in our thymic carcinomas. Our thymic carcinomas are going to be much more invasive and they're going to lack those fibrous bands. So at this point, we're going to pretend that our thymoma or our lesion is completely involving our cut surface, which is pretty common with thymomas. In that instance, we won't have any uninvolved parenchyma to describe. That will still be a pertinent negative that we'll want to document. But if our mass was not completely involving our thymus, we would need to measure our mass in 3D and give our descriptions. But in this case, we're going to say it completely involves our specimen, so our measurement for our mass is going to be exactly the same as our measurement for our specimen overall. So we've given our measurement. Now we can describe. In our thymomas, we would want to make sure we include if there's those fibrous bands, because those are indicative of thymomas. We can give our relationships to any other structures from the mass. So we would want to measure our mass to our margin or our inked outer surface. In this instance, we would only have one measurement, and since our lesion is completely encompassing our specimen, it's inherently going to abut our inked outer surface. If it wasn't involving the entire specimen, or you had orientation, you could provide the measurement of the mass to your closest inked outer surface or to your anterior and posterior surfaces. Then, after you've given all of your descriptions of your mass, you can describe your uninvolved thymus parenchyma. In this instance, we don't have any uninvolved parenchyma remaining, so we would give that as a pertinent negative. The other thing that we want to make sure we comment on with our mass, and if we know that we have adherent structures to the outer surface, so measuring the distance of that mass to those adherent structures, discuss if the mass is involving those adherent structures. That will be pertinent for staging purposes. So when we go on to take our sections, we want to make sure we give one section per greatest dimension of the mass. So we know our specimen was about 9.5 centimeters, so I'll round up to about 10 centimeters. So when I take my sections, I want to make sure that I have sections of the mass and all of its relationships. So our mass to our capsule, mass to uninvolved, mass to any adherent structures. In this case, we don't have any uninvolved or adherent structures, so we're just going to take representative sections. But when we think about staging for thymomas, we have a couple things that we need to be worried about. We need to think about the size of the mass, because our mass, if it's less than or greater than 5 centimeters, that will differentiate from a T1A or a T1B. If it's less than 5 centimeters, it can be considered a T1A. If it's greater than 5 centimeters, it would be a T1B. Now, there are some nuances with staging. The size component is only for T1. If we start getting into invasion for our thymomas, then we are starting to get into that upstage criteria. So for our T2s, it could be 3 centimeters, but if we have involvement of the lung, we're automatically going to be upstage to a T2. Some other things that our T2 category could involve would be our pericardium or the phrenic nerve. And when we start getting into our T3 and our T4, we're getting to our more extensive involvement with our superior vena cava, our pulmonary arteries, the chest wall, the aorta, so on and so forth. So I have 1, 2, 3, 4, 5, 6, 7, 8, 9, 10 sections of mass and its relationships. And then if I had any uninvolved, I would throw it in this last cassette. In our sections, we want to make sure we get those relationships if we have them. And the other thing we want to do before we close out our case is we want to look for any lymph nodes. We didn't have really a ton of adipose tissue on the outside of this thymus, but we would palpate through the adipose tissue, document any lymph nodes if we find them, describe what they look like, and give a range of greatest dimension. All of our lymph nodes we would submit entirely. And that's pretty much all she wrote for a thymoma. So you will be doing one of these in lab this week. And if you have any questions, feel free to let me know.